So this is going to be our first module 1 out of 4 on acute dyspnea series. And why acute dyspnea? I chose this topic because it's one of the most common acute emergency presentations all over the world. And the basic rationale behind all this module is that we need to go from a panic mode to a precision mode because the stakes are very high. It's a very high stake consult, and it can require immediate life-threatening assistance for patients presenting with this presentation. So what exactly are we going to be doing in these 4 modules? This first current module is the fundamentals, which is basically focused on the clinical, the definitions, clinical epidemiology, global burden, and classification in terms of very nice algorithms, and we'll go through some of the learning tips. This is the module 1. Then in modules 2, 3, and 4, in module 2, we are going to discuss about the ED approach in a very, very nice practical algorithm, which is pivotal relay, and this is one of my most favorite parts in the entire series, which will be diagnostic flowchart, and also it will then lead to the history and examination with clinical reasoning and pearls and combination of different sets of presentations, which will make it easier. Then in module 3, we are going to discuss about the management, which is investigations and with some clinical cases, and also the management principles of acute dyspnea. And finally, and remember, in all the 3 modules 1, 2, and 3, there will be exam corners and exam tips, which will be based on USMLE, MRCP parts 1, 2, PACES, OSCE exams, etc. But in the final module, I'm going to wrap it up as an exam corner about all these learnings that we have done in the first 3 modules, and we are going to cap them up as a nice revision module for acute dyspnea, so that if anyone wants to just focus on that particular aspect, then they can do so. So please stay tuned. It's going to be a very nice journey for these 4 modules. And also, please don't forget to subscribe to the channel and like this video and press the bell icon so that you can receive notifications for all the exciting videos, not only this module but also for all future interesting modules coming up. And also please do drop comments about this video and any questions you might have, and it will lead to nice engaging discussion. So one of the key things for all the trainees over there, at the start of this module, I know the anxiety level is high and the precision may be a bit low, but this is what the whole aim is for over these next 4 modules. What we are aiming for is for this anxiety of dealing with such patients is going to taper off, especially when you reach towards module 3 and 4 as exam corners, and the precision or confidence level should go high. So this is the transformation of the journey from high anxiety to clinical mastery. Now this is another way of understanding the concept of this module series, that in the usual standard lectures, you can see the curve in the middle, the line charts in the middle, that the definition, epidemiology, ED flow chart, clinical cases, exam corner, practical management tips. So that might be a bit limited, but in this series we are I'm going to encompass, and we are going to encompass everything in more depth and practical manner, and hence the value, the cumulative value in all these 4 modules will be far greater. And coming on to the fundamental module, module 1. So basically we are going to touch upon the definition part and what does acute dyspnea mean, followed by clinical epidemiology and the global burden. And eventually we are going to discuss about the physiology and pathophysiology, and then the clinical cases and the classification system, and eventually followed by conclusion and summary. So the very first question is, what is dyspnea? And then we'll come to the acute dyspnea definition. So the American Thoracic Society defines acute dyspnea as a subjective experience. Remember, it's a subjective experience by the patient of breathing discomfort, which consists of qualitative distinct sensation, which is variable in intensity between different patients. So the crucial distinction is that what the patient feels as a symptom, and the sign, which is the objective part. So subjective part is the patient's sensation, while the objective part could be tachypnea or hypoxia, because we may not attribute breathlessness with it's a common misconception that hypoxic patient is breathless, or every breathless patient is hypoxic. Both may or may not be true. So hence it's really important that it could be tachypnea, it could be hypoxia. So this is a clear important distinction to make. Now, let's come to the language of dyspnea. And really, to be honest, this is my most favorite, or one of my most favorite slides. I think if you focus on this one, you will learn a lot. Now, we think of acute dyspnea as a medical terminology. We think, oh yeah, it's an acute dyspnea, acute breathlessness. But the patients do not come and say, doctor, I've got acute dyspnea. Or they will not say, they just don't say that I'm short of breath. Yes, they do, but in a way, we have to be more specific. From history and exam point of view, or from history, we always say that, okay, start with open-ended questions. Ask the patient, what do you mean? We don't say, are you short of breath? Do you have chest pain? Those are closed-ended questions. Is it pleuritic? Is it this? Is the breathing tight, tightness in your chest, or you're not able to get enough air in? Those are all closed-ended questions. We always start off with open-ended questions. Ask the patient, okay, what brings you to the hospital? What's wrong with you? Can you describe your symptoms? They might start off by saying, oh, I'm short of breath. Then you say, okay, fine. Can you describe it in a little bit more detail? So this is a paramount in importance, this particular aspect. Now, the three main aspects of patient symptomatology in this situation, please remember, these are air hunger, chest tightness, or increased effort. So there might be a combination of these different presentations. So let's look at them one at a time. So when it's air hunger, the patient means I cannot get enough air. So that's what they would describe. I'm literally hungry for air to get into my chest or the lungs. Why does it occur? We will come to the pathophysiology and the physiology later on, but in more detail. But basically, it's a mismatch between the demand and supply, the driver, which is the brain respiratory control, and the intake, the mechanical aspect of the driver translating into the chest wall and alveolar arterial oxygenation. So we'll come to that. The usual examples are pulmonary embolism and heart failure. Now, one of the key concepts here is, if you remember from your physiology, is what is called either the lung dead space or shunt. So what does a dead space means? It means it's a space which is ventilated, but it's not perfused. So there is air in, but there is no blood flow. The commonest example is pulmonary embolism. So the air is there, but there is no blood to take it because there is a blood clot sitting somewhere, and hence the pulmonary circulation is compromised in that aspect. On the other hand, there's a shunt. Shunt means the blood is coming, but there's no air to take or exchange, like no oxygen, carbon dioxide exchange happening around it. So think of an alveolus, my hand like an alveolus, and think of the blood supply coming in. So essentially, the alveolus air is replaced with something, and that something is usually fluid or tenacious, or tenacious material, or something like consolidation, pulmonary edema, heart failure. So when you have such a situation, that is called shunt. So whenever there is a mismatch between the two, that leads to the air hunger sensation. The second concept is chest tightness, which means the patient will say, my chest is so tight, I cannot breathe in. So the physiology here is the receptors in the alveoli, the airway, the bronchi. We'll come to that in pathophysiology in more detail. And the classic example is asthma and bronchospasm, so where there is mechanical obstruction to the flow of the air through those pipes and airways inside the lungs. So that leads to the chest tightness. So they feel that they're suffocated. They cannot, the chest is really tight. It's not a relaxed, normal breathing. So it sort of feels squeezed, literally. The third one is the increased effort. So the patients describe as if it's a hard work for me to breathe. And here the pathophysiology or the physiology lies in the increased mechanical load, which is in a way similar to the chest tightness type. So whenever there is COPD, chronic obstructive pulmonary disease, especially when there is an acute exacerbation of that, so that means the patients have to work harder. The mechanical load is so intense because of the constant bronchospasms, whether it's emphysema pattern or the chronic bronchitis pattern. In both COPD spectrum, we've got higher mechanical load to the breathing effort, to the ventilatory drive. And or it can also be due to the neuromuscular weakness, where the primary muscle controls to the diaphragm, intercostals, that is affected, whether it's through myasthenia or Guillain-Barré syndrome. So it's really, really important to focus on the three concepts, which is the language of dyspnea, because I think if you can understand this concept, you will be able to piece together the physiology, pathophysiology, the different classifications which we will discuss later on. So I've spent a lot of time on this slide, but that is because it is crucial, pivotal, vital for all of you to understand the concept of the language of dyspnea, which is used by the patients, not what we have to say. So please let the patient describe what they feel, and then that should give you diagnostic clues towards the proper history and the proper differential diagnosis based on the history, which history makes 60 to 70% of the diagnosis. Examination further narrows it down to by another 15 to 20%. So you've got about 80 to 90% based on history and examination. The last 10% for a good astute physician should be the refining of those differential diagnoses, let's say from 5 to 3 or from 3 to 2 or from 3 to 1 eventually through investigations. Nowadays, unfortunately, it's the other way around. We sort of think about sending off dozens of investigations and hoping one of them will be correct and not focus too much on the history and examination part. So this is where the clinical reasoning comes into play, which is a core ethos of this particular channel. So taking it further to synonyms and clinical context, so now it will tie in very nicely. So some of the common patient phrases will be, doctor, I'm short of breath, I'm feeling breathless, I find it hard to breathe, I'm finding it difficulty in breathing, I really cannot catch my breath, I feel suffocating or smothering. So these are some of the variable synonyms which the patients can use. When we talk about dyspnea, remember this module is acute dyspnea. We are not talking about the chronic shortness of breath, NYHA grades 2, 3, 4, gradual heart failure over a period of time and ILDs and all those. This is more of acute. So in acute, by definition, the symptoms are sudden. So usually it occurs pretty rapidly from minutes to hours, but maximum just a few days. We are not talking about here weeks to months. That is where it comes to the chronic territory. And the core concept of this acuteness of the dyspnea is basically the neuromechanical dissociation. We'll come in, we'll discuss it later in more slides with a few diagrams as well. So the brain component versus the muscle and the lungs component. So whenever there is a neuromechanical dissociation and there's a mismatch between the two, that actually leads to the symptoms of acute dyspnea. So taking it further, as I discussed in the previous slide, acute versus chronic dyspnea. So we need to differentiate between the two before we move forward. So acute dyspnea by definition, as we said, is sudden, occurs over minutes to hours, maximum days, like acute exacerbation of asthma and COPD can be over maybe a couple of days. Against that, acute pulmonary embolism, acute pneumothorax will be fairly sudden, literally within seconds or minutes, and maximum a few hours depending upon the speed of onset really. The common causes, as I said, acute asthma, pneumonia, acute pulmonary embolism, acute MI and leading to decompensated heart failure or flash pulmonary edema, anaphylaxis, anxiety or panic attack. The urgency is because of the rapidity of onset of the presentation and the seriousness. Usually it's pretty urgent, requiring prompt evaluation and intervention, hence this particular module. Now, differentiated from chronic dyspnea. So the onset is gradual. It's like subacute to chronic, hence the name. It develops over weeks, months, or maybe longer, and tends to be persistent, or there can be acute exacerbations, acute flares on top of the chronicity. So chronic ILD, acute exacerbation due to an infection. Chronic stable COPD, usual baseline breathlessness, then intermittent fluctuations with the flare, and then dip back to the baseline, or may not be the new baseline. That's where the progression of the disease and asking about the functional quality of life and how is it affecting the best exercise tolerance, etc., etc., etc. We'll come to that. Coming to the common causes of chronic dyspnea: COPD, heart failure, chronic decompensated congestive cardiac failure, all grades of heart failure, HFpEF, HFrEF, chronic pulmonary hypertension, interstitial lung disease, as we said, or physical deconditioning from any cause. Urgency, it's a long-term issue. Chronic disease management, usually community management from primary health care. The GPs are fantastic in dealing with these conditions in the community. So that's what the differentiation is. Unless there is an acute exacerbation which requires prompt intervention or inpatient in-hospital stay in all these conditions. So that's the differentiation between acute versus chronic dyspnea. So let's just briefly go through the importance of acute dyspnea. Why did I select this as the first topic of my YouTube channel? Because it's one of the commonest reasons for emergency presentations all over the world, whether it's Western Hemisphere or European subcontinental Europe, or Eastern nations like Southeast Asia, etc. It's one of the commonest presentations and is associated with significant acute short-term mortality risk in hospital. Plus, it has consequences for long-term morbidity and mortality as well. And the stakes are very high because acute dyspnea means there is an acute either airway problem or breathing problem, the AB in the ABCDE algorithm for resuscitation. Hence, it's really imperative for us to have a better understanding of this module. When we look at the epidemiology and the global burden, as I just mentioned earlier, it's like around 3 to 5% of the ED visits. But in contrast, almost half of the patients who present with acute dyspnea to ED, they get admitted. And it's amongst the top 3 ED presentations all over the world. Now, why does it matter? Because if you just compare it with acute chest pain, around 1 to 2% of those patients are actually admitted and the rest are discharged. So it clearly means that the patients with acute dyspnea are sicker and hence require more hospitalization as compared to other presentations. And if you look at the prognostic factors, we have looked at the age, which is a very strong predictor of mortality. Tachypnea, anyone with a profoundly high respiratory rate, and we discussed that one of the first physiological signs which will go abnormal due to any acid-base balance problem, especially with acidosis, will be tachypnea, because the chemoreceptor trigger zone in the brainstem immediately is activated due to that response, and that increases the ventilatory drive and has to try and to blow off the CO2, which is an acidic gas, in an attempt to normalize the acidemia. Hypoxia, any SATs of less than 90% is another trigger and also a poor prognostic factor. And comorbidities, renal failure, dementia, etc., even diabetes. So all these risk factors carry a poor prognosis in terms of mortality and morbidity. In terms of readmissions, we also know the frequent flyers. So patients with COPDs and heart failures, they have a very high 30-day readmission rates. Roughly like 1 in 4 to 1 in 5 patients discharged from hospital will eventually require a readmission within 30 days. So over the next few slides, let's have a look at the basic pathophysiology of acute dyspnea. To understand that, we need to understand the 3 core components of respiratory control, which is the controller, the pump, and the gas exchanger. So the controller is the CNS respiratory control in the brainstem, including medulla and pons, where the primary respiratory centers are there, and they're receiving afferent from different receptors. We'll come to that in a while, and they relay eventually to the cortex. Now the controller basically then leads to the neuronal signals to the pump, and the pump includes the chest wall and the primary respiratory muscles. So the chest wall and the muscles including a diaphragm and intercostal. So once the pump receives the efferent input from the controller, which is the brain, that leads to the mechanical response to those triggers, and eventually that translates into the third component, which is the gas exchanger, which is at the pulmonary vascular bed, so where the oxygenation and the blood flow are meeting. So that's alveolar arteriolar gas exchange of oxygen and carbon dioxide in the opposite directions at the alveolar level. That leads to the ventilatory mechanism, the ventilatory drive. Hence, oxygen gets into the blood and CO2 is removed. So that is what happens in the normal physiological response. Now, whenever there is a neuromechanical dissociation, which is also called afferent-efferent mismatch, that is where the demand and supply principle comes into play. So if the motor signal by the controller is not translated into the desired outcome by the pump itself, that leads to the mismatch, and that is eventually perceived as a strong symptom of acute dyspnea by the patients. Now in the previous slide we discussed about the pathophysiology. So now let's focus on the actual the afferent input towards the central nervous system. So we talked about the afferent component or afferent limb of the mechanism of sensation, how is the respiratory or the breathing control sense. So Basically, there is a combination of chemoreceptors, mechanoreceptors, and the J receptor. So the names are self-explanatory, but let's look into them in detail. So the chemoreceptors, as the name suggests, they are to sense the chemical changes like the pH, acid level, bicarbonate, carbon dioxide. So anything which has to do with acid-base balance, that is the first point of defense. As soon as there is any changes in the pH, the respiratory drive immediately tries to blow off the carbon dioxide, which is an acidic gas, to try and neutralize the effect. And then the metabolic component, metabolic compensation of retaining bicarbonate through the kidneys, is a longer process which starts in minutes and can take up to a few minutes to a few hours for proper effect. But the immediate one is the respiratory drive. So the chemoreceptors, the location is in the brainstem, like medulla oblongata and the locus coeruleus, and also it's located in the carotid bodies and aortic bodies next to the aortic arch. The stimulus, as we just discussed, what are they sensing? So that's the location. The stimulus is the hypercapnia, hypoxia, acidosis, or any combination thereof. And what is the effect? It leads to increased respiratory drive, which in itself will lead to air hunger or in the sensation of acute dyspnea. So that is the chemoreceptors. Now, mechanoreceptors, as the name suggests, these are responding to the mechanical stretch, and the location is virtually throughout the airways, lungs, pulmonary vessels, the chest wall, and the respiratory muscles. So they are mechanical receptors. So once there is increased work of breathing, so the stimulus is, the increased load or restriction to the working of these mechanical receptors, and that leads to a sensation of chest tightness or increased effort or work of breathing. Then coming on to the J receptors. So these are located, as the name suggests, juxtacapillary receptors. So these are next to the capillaries in the lungs, and they are the tiny sensory nerve endings located in the interstitial tissue, right next to the cellular level, as we were discussing at the alveolar arteriolar exchange. So they are next to the pulmonary capillaries, and predominantly they are rich in abundance near the alveoli. So as the name suggests, the moment there is any abnormal secretion or material in the alveoli, that means if the air is replaced with a fluid, pulmonary edema, or if there is pulmonary embolism, or there is pneumonia or consolidation, they sense, and that eventually also leads to the effect is a rapid shallow breathing, because they're trying to hyperventilate. So these are the three main mechanisms of sensory input, or the afferent input to the brain itself. This is a summary of the pathophysiology that we have discussed so far, more in a flow chart manner. So as you can see, the pathophysiology is basically the respiratory sensations. We just discussed about the sensation of air hunger and chest tightness, which the patients perceive. And it has three components: the neural and sensory component, as we discussed, the brainstem and the motor cortex, and the sensory cortex as well. So after that sensing component, you've got the afferent signals, which, as we discussed, are the mechanoreceptors and the chemoreceptors and the J receptors, signal towards the neural and sensory components. And finally, the efferent signals are relayed through the motor components of the nervous system to the respiratory muscles of chest wall, diaphragm, and intercostal, eventually leading to the ventilatory drive. And this is just a nice summary of what we have discussed so far. In terms of classification, you will find many different schools of thought, many different approaches, and all of them are correct actually, as long as you just stick to the basics. So you can classify the etiologies or the causes of dyspnea according to the speed of onset, the time course, or by systems. So both of them have their own implications. I think the history of presenting illness will be crucial here. So if it's hyperacute onset of dyspnea, then you need to think about causes like pneumothorax, including tension pneumothorax, pulmonary embolism, acute pulmonary embolism, or anaphylaxis, to be in that respect. Or it could be acute flash pulmonary edema due to sudden cardiac mechanical issues, a valvular rupture, or a ventricular septal defect, or any etiology which leads to sudden acute flash pulmonary edema, like in seconds. Or it could be in hours rather than minutes. So if it's not hyperacute, then you can think about etiology of hours, which could be any obstructive airway disease, decompensation of asthma, COPD, acute heart failure, which is not like flash pulmonary edema, and also pneumonia, which can develop fairly rapidly within 24 hours. Then if it's subacute, which is lasting up to a few days, then you can think of chronic heart failure, think of causes like gradually developing pleural effusions or anemia. So this is one way of classifying. Then you could also classify according to systems. The predominant one is the respiratory system itself, which could be airways, parenchyma, or the pleura. It could be the heart, the pump itself, the pump failure. We'll come to that in a bit of detail. And it could be any part of the heart, the myocardium, the pericardium, endocardial aspects, the valve. It could be the control, the neuromuscular, so Guillain-Barré syndrome, myasthenia, something that affects the respiratory muscles in the drive. Or it could be purely just metabolic, and the breathing is due to a response. We were just discussing about the CO2 chemoreceptors. So anything which can cause acidosis, whether it's sepsis, metabolic causes, renal failure, all those mud piles, mnemonic, the methanol, uremia, diabetic ketoacidosis, etc., poisoning, paracetamol, toxic substances, all of those causes of etiology of acidosis, that can lead to shortness of breath, which is not a respiratory cause per se. And same as anemia. So yeah, you could classify according to time course or by system, and I think both will be helpful in clinical context. Now this slide is just another reminder of how to put things into context. So if you look at the diagnostic buckets point of view, the etiology in predominantly 85% of patients with acute dyspnea is either pulmonary or cardiac or a combination of mixed cardiopulmonary. So this is a huge chunk. So while the other 15%, do not forget, we were just discussing in previous slides. So again, if it's a metabolic acidosis due to DKA or uremia or any condition, or hematological causes like severe anemia, psychogenic, we were discussing at the very start of the presentation that some people may just present with the subtle benign etiology, but they have to be a diagnosis of exclusion rather than inclusion at the start, or neuromuscular. So these 15% form the rest of the bucket. This particular slide, I actually like it so much because this actually sums up what we just discussed in the last two slides. And if you can recall, the 85% of the causes of the cardiorespiratory and a combination, and the rest of the 15% bucket, this sums it up actually. And in a very nice the memory aid or aid memoir, to be honest, if you see, these are like the 5 P's framework for acute dyspnea. So you have pump, pipes, parenchyma, pleura, and psyche and pH. Now, if you look closely, the first 5, so the pump is the heart itself. Anything related to cardiac issues, will come to those causes in a little bit of detail. The rest of the 3, the pipes, parenchyma, and pleura, are actually respiratory. So pipes are the paths, the airways leading from the oropharynx towards the lungs, and the parenchyma. Then eventually you've got the lung parenchyma itself. So airways, lung parenchyma. Finally, going out of the parenchyma, you have the lung pleura. So this really helps you in understanding the pathophysiology and the causes. So these, the pump, pipes, parenchyma, pleura, are 85% of the bucket. Then the psyche and pH, psychological causes, anxiety, hyperventilation disorders, and then pH means all the acidosis related complications. So this is the 5P framework for acute dyspnea. Let's come to the first exam corner. So whenever you have etiological question about etiology or causes of acute dyspnea, always think of those 85% causes and then 15%, and the 85% you have cardiac versus pulmonary versus others. So cardiac, pulmonary, and cardiopulmonary combination and others. So when you have this approach in mind, depending upon the question, if it's a pure step 1 question, you might have just a basic information. But if you have a clinical question with a bit of scenario, always think of this systematic approach, and hopefully you will be able to get the correct answer if it's best of 5 or multiple choice attempts. So I think this is the most important part of this particular module. So understanding the classification in a little bit more detail in a very schematic manner. So I really like this particular concept. Now, we have discussed previously in earlier slides about the etiology, as in 85% of the causes related to cardiac, pulmonary, or a combination of the two. And also the remainder of the 15% to be metabolic, psyche, and also remember those 5 P's that we've talked about earlier before. So pipes, pump, parenchyma, pleura, and psyche and pH. So putting all those into context. Now, I've got very nice algorithms. I'm just going to talk them through. The first one is this one is the pulmonary and thoracic causes. We will split them into two different down the line. Then we have the cardiac causes, finally metabolic, and then miscellaneous. So these are 3 or 4 different algorithms. Now, if you focus on the pulmonary causes, I think this vertical classification system is based on, think of the air which is breathed by the patient or by anyone, to be honest, from nose and mouth towards the lungs, and that flow of the air, the anatomy or the route taken, and eventually out towards the periphery will guide you towards the causes. So first of all, you've got the larger airways, so trachea, main bronchi, so those are the larger airways. Then you've got etiology for the smaller airways, so bronchioles, segmental, subsegmental bronchioles, and finally so these are the 2 etiologies, so larger airways, smaller airways. Then you got in etiology for the infections, infectious etiologies for acute dyspnea. After the infection, and infection can affect any part, smaller airways, larger airways, and the lung parenchyma itself. After infection, you've got another group of conditions, which is the interstitial lung disease. So now you're talking about the interstitium in the lung itself. Once this lung part is covered, now you're talking about the pulmonary vascular disease, so anything affecting the blood flow in the lungs. So that has a separate category. Once you have dealt with all of them, eventually you're talking about the outside of the lung part, which is the pleura. So the pleural space or the pleural disease itself will lead to some of the etiologies. Having dealt with the pleura, now we are coming out of the lung towards the respiratory muscles. So diaphragm, intercostal muscles, anything affecting the muscles, the ventilated drive we discussed. If you remember the mechanical part of the brainstem control, the brain is a driver and then eventually delivers through the mechanical part. So neuromechanical dissociation leading to the problem. So here we are talking about the mechanical dissociation, so respiratory muscle weakness. Out of the muscles, you come out, the final part is the chest wall itself. Anything affecting the chest wall will lead to acute dyspnea. So this is a very, very nice way of remembering. I loved this particular classification when I came across. So larger airways, smaller airways, infection, interstitium, pulmonary vessels, pleura, respiratory muscles, chest wall. Excellent. So coming on to the pulmonary and thoracic causes in a bit of more detail, we will split it into 2 different slides because it was a very different, very large flow chart. Firstly, large airway disease, anything affecting the larger airways, trachea, bronchi, with foreign body, and in like a large mucus plug, etc. So any stridor from the partial obstruction of the trachea or upper airways will lead to acute dyspnea. That's why in ABCD approach we have the A, which is looking for the patent airway, and that can be life-threatening consequences if there is a larger obstruction of the larger airways. Hence, and no air can flow in, and it can lead to potentially life-threatening problems. So that's large airway disease. Also, it can be slightly distal in terms of the lobar collapse due to a mucus plug or a tumor or a foreign body, and hence it can lead to partial atelectasis or complete atelectasis of that particular part or segment, or segmental or subsegmental, or even a total lung collapse on that particular site. Coming on to the smaller airways, so anything affecting smaller airways like asthma, COPD, acute flares, anaphylaxis, can lead to acute dyspnea, and we discussed previously in the increased effort of breathing. So whenever there is narrowing of the smaller airways, which is pretty much diffused throughout bilaterally, that leads to more resistance to the airflow and expiration, and hence the patients are unable to ventilate and breathe properly, especially the oxygenation part, because the airways are so narrow that they cannot take in sufficient oxygen. And that usually leads to type 1 respiratory failure and acute asthma, where oxygenation is a problem, and or type 2 respiratory failure in conditions like COPD, where the ventilation is a problem. So hence they are unable to blow off the carbon dioxide. So again, depending upon the long-term problems of COPD or asthma, it can be type 1 versus type 2 respiratory failure. So anyhow, that's a more detailed discussion for another module down the line. Acute anaphylaxis will also lead to inflammation of the smaller airways, so that can lead to acute dyspnea as well. Similarly, you've got conditions like bronchiectasis. So the bronchiectasis is a condition or a disease affecting the dilatation, the permanent dilatation of the part of the bronchi proximal to the terminal bronchus, terminal bronchioles. So that is bronchiectasis. Bronchiectasis, which means ectasia, dilatation. While this differentiates from emphysema part of the COPD, which is the part of the airways or the alveolar sacs which are affected distal to the terminal bronchioles. So proximal is bronchiectasis, distal is emphysema. So bronchiectasis, especially acute exacerbation, will also cause acute dyspnea. Coming on to the third category of acute dyspnea in the pulmonary causes is infection. So infection of any part of the lung itself can lead to acute dyspnea. So if it's consolidation or replacement of air in the alveoli and with pus or infectious material or tenacious material, that will lead to pneumonia, which is usually bacterial. However, especially if it's unilateral involvement, especially on the chest x-ray, so radiological confirmation of the airspace opacification. Obviously, we cannot say pneumonia, we describe what we see on the x-ray. So it's usually bacterial, especially if it's unilateral, although bilateral can also be, but in 10% of the cases it can be viral pneumonias, and usually viral are bilateral in elderly, and even in young patients they can be affected. So as we are seeing it a lot in the world right now in autumn of 2025/January 2026, there are lots of cases of post-COVID phase. Now COVID is few and far between cases. We are seeing a lot of influenza, respiratory syncytial virus, all the respiratory viruses, the non-COVID-19 viruses are causing a lot of severe bilateral pulmonary pneumonias and inflammation, especially in young patients as well, and also in elderly population. Also, we have bronchitis, infectious bronchitis, usually upper airway disease, a lot of secretions, bronchoria. This is viral. Then you've got pneumonitis, which can be infectious or non-infectious, and it's a inflammation of the lung parenchyma, or the lung tissue itself, rather than pneumonia, which is usually affecting the alveolar part. Tuberculosis in immunocompromised patients, previous history, endemic areas. That's usually more of a chronic presentation, but in acute exacerbations, or if there is a dissemination of tuberculosis like miliary tuberculosis or acute presentations, think of acute dyspnea in those conditions, or tuberculosis leading to complications, tuberculous empyema, tuberculous pneumonic effusion which has suddenly deteriorated, etc., or acute hemoptysis leading to problems, or even other systemic complications. Also in infections, do not ignore about HIV associated infections like pneumocystitis, pneumonia, or PCP infections, which can be acute, which can present with acute breathlessness. So if anyone with immunocompromised state, IV drug use, or any previous history of immunosuppression with bilateral florid presentation, the patients are usually quite sick with PCP pneumonias. Then after infections, you have etiology of interstitial lung disease. So anything which affects the interstitium, whether it's due to cryptogenic alveolar fibrosis, fibrosing alveolitis, or idiopathic pulmonary fibrosis, IPF, or ILDs, or interstitial pneumonias like bronchiolitis obliterans, so BOOP and the croup, cryptogenic organizing COOP, which is cryptogenic organizing pneumonias, sarcoidosis, occupational diseases like asbestos and pneumoconiosis, and also acute allergic alveolitis like hypersensitivity pneumonitis, HSP, or bird fancier's lungs, farmer's lungs, all those conditions. So again, depends upon the detailed history and examination. Similarly, drug-induced interstitial lung disease is not uncommon at all. Amiodarone, methotrexate, a lot of those conditions. Although not mentioned here, but you also think about radiation pneumonitis. Anyone with previous history of radiotherapy to the lung because of underlying malignancies, that can also be one of the causes of interstitial lung disease leading to a shortness of breath. And lastly, you have conditions like pulmonary vasculitis, which can be a primary pulmonary vasculitis, meaning that only the lung parenchyma or the lung bed is involved, or it can be part of the systemic vasculitis with maybe CNS, renal involvement, other involvements, sometimes mesenteric ischemia. So again, pulmonary vasculitis, do consider anyone presenting with multi-system etiologies and when it's not fitting into one domain. One other point I just wanted to mention that the pneumocystis carinii pneumonia, the PCP, which was the previous nomenclature, currently it's the new name is pneumocystis jirovecii pneumonia, PJP. So please do remember that as one of the exam questions. So the next categories are pulmonary vascular disease, anything affecting the blood supply to the lungs, so pulmonary embolism or pulmonary hypertension. Once we have covered the pulmonary vascular, then we have pleural diseases. If now we are moving out towards the periphery of the lung, and outside of the lung you have got the lung pleura. So think of the pleural diseases as etiologies to be predominantly either the pleura themselves or anything between the visceral and parietal pleura. So if there is air between the visceral and parietal pleura, that's pneumothorax, that can lead to acute dyspnea. If it's fluid, that will be pleural effusion. If the fluid is, you need to assess whether it's unilateral or bilateral. So usually the bilateral pleural effusion is due to a systemic cause, because it's most likely a manifestation of the systemic disease leading to pulmonary presentation, especially bilateral pleural effusion. So it's usually transudative. Congestive cardiac failure, decompensated congestive cardiac failure is one of the commonest causes of bilateral pleural effusion. Although cardiac failure can also lead to unilateral effusion, so don't be confused when it's unilateral only. Also, hypoproteinemia due to any cause, renal losses, GI losses, any conditions, chronic malnutrition, anything which can lead to hypoproteinemia will reduce on-cortic pressure, and hence the fluid is unable to stay inside the vascular space and is leaked out into the third spaces, including pleura. Same mechanism as for ascites. So these are the diseases not primarily affecting the pleura themselves, but the functional space is now increased between visceral and parietal, leading to pneumothorax or pleural effusion. Then coming on to the pleural disease itself, it can be either pleural thickening or fibrosis due to any cause, or mesothelioma. So we can't go into much details, but these can be other reasons for presentation. Now we have gone from the airways to the interstitium to the vascular to the pleura. Let's come out of the lungs and the surrounding pleura themselves. Now we are talking about the respiratory muscle weakness. So anything which leads to diaphragmatic muscle paralysis, like neuromuscular diseases, Guillain-Barré, or phrenic nerve palsy, which can be iatrogenic or due to a primary disease itself, or neuromuscular conditions like muscular dystrophies or motor neuron disease. However, those are usually chronic causes of shortness of breath rather than acute as such, except Guillain-Barré syndrome, which can be more subacute. Finally, we are talking about the chest wall disease itself. So once we are out of the respiratory muscles, we are talking about the chest wall itself. So anything affecting the chest wall muscles themselves, the chest wall, the bony skeleton itself, like severe scoliosis or any previous thoracic wall surgery like thoracoplasty performed before, can lead to shortness of breath. However, both respiratory muscle weakness and chest wall diseases usually are subacute or chronic causes of dyspnea rather than acute. This slide, I'm not going to go into details, but essentially it's just a graphic summary of the predominant pulmonary etiologies. Airway disease, you can look at the diagnosis, parenchymal, and finally vascular. So after pulmonary causes, the others are cardiac, metabolic, and miscellaneous. So this is just the second arm of that vertical classification. I'm just going to go into the cardiac causes in the next slide, and then metabolic and miscellaneous. But it's just for you to have a look at the predominant etiologies as one diagrammatic representation. Now, in terms of the cardiac causes, just like we discussed the pulmonary causes, so we went through anatomy of large airways, small airways, etc., 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 then going outwards towards the lung parenchyma and then the periphery of the lung itself. Think of the heart in a similar manner. So that's the key thing for all the trainees and physicians to understand. The predominant one will be the cardiac muscle itself. So anything to do with the myocardium. So the top three etiologies: left ventricular failure, ischemic heart disease, and then cardiomyopathy. So these are predominantly affecting the chunk or the crux of the heart muscle itself. Then followed by valves, pericardial disease, and then the conduction system. So if we have this in mind, it makes it a little bit easier to understand. So the predominant cause of acute dyspnea in such patients is the left ventricular failure, which is usually in an acute case is the predominant cause of acute dyspnea, like acute pulmonary edema, which can be flash pulmonary edema, decompensation of the previously known congestive cardiac failure due to any cause, a viral illness, an acute MI, an infection, volume overload, non-compliance. So whatever the etiology is, but anything leading to acute pulmonary edema will be due to the left ventricular failures. And why left ventricular? Because left ventricular failure leads to the higher end diastolic pressures, which are transmitted backwards towards the lung parenchyma, and hence there is congestion and oozing of the fluid into the lung parenchyma, leading to alveolar arteriolar oxygenation mismatch. So again, we were discussing about the shunt, if you remember. So the shunt means the blood supply is there, but there is no oxygen to pick up from the alveoli due to the liquid or tenacious or pus or any other materials. In this case, it's predominantly the fluid. So that is left ventricular failure. Similarly, ischemic heart disease, which also leads to demand supply mismatch to the myocardium, and that leads to chronic shortness of breath, which can also eventually lead to acute decompensated heart failure. Cardiomyopathy is a wide term, as the name implies, cardiomyopathy. So heart muscle pathology, anything other than ischemic cardiomyopathy, hypertensive cardiomyopathy, etc. And also it can also be a viral myocarditis or viral cardiomyopathy, usually acute. Peripartum cardiomyopathy, during which occurs during the in and around the puerperium and the childbirth. Alcoholic cardiomyopathy, usually chronic. So think of cardiomyopathy as a broader group of etiology which can lead to. So essentially, cardiomyopathy and heart failure will be intertwined, but it's more of a from pathophysiology point of view. Now, other than the heart muscle or the myocardium itself, we have the heart valves. Any valvular heart disease, whether it's acute rupture or one of the chordae tendineae is ruptured, or any decompensation, or if there is a previously known valvular etiology and now there is an acute decompensation that can lead to acute heart failure. Ruptured chordae tendineae is a very common example. In acute MI, there may be a part of the heart valve which is physically damaged, and hence the rupture of one of the three cords can lead to the valvular dysfunction, and hence the ejection of the blood from the left ventricle, and instead of going towards the aortic valve, some of it regurgitates back to the left atrium through the ruptured mitral valve, and hence that leads to the back pressure towards the lung, and that leads to acute pulmonary edema. So this is one of the simplest etiologies. Same as aortic stenosis. If there is forward outflow obstruction, that can lead to decompensation and shortness of breath, and eventually the same phenomena. So valvular heart disease, one etiology. Coming on to, if you come outside of the heart, you are talking about the pericardium. So any pericardial disease, constrictive pericarditis due to tuberculosis, rheumatoid arthritis, or pericardial effusion of any cause, whether it's infectious, inflammatory, malignant, tuberculous, any etiology, with or without tamponade, with or without any other problem. So pericardial effusion on its own, because that physically squeezes the heart muscle itself, or the myocardium or the heart. And constrictive is the worst part, because in this the fibrosed pericardium itself doesn't allow the heart to relax completely, and hence the diastolic phase, there is no inflow or reduced inflow of the heart, of the blood flow into the heart, and hence the forward failure also occurs, because there is not enough blood coming into the heart, and hence the ejection fraction, the Frank-Starling law. So the end diastolic pressure will eventually determine the systolic amount of the blood which goes out. So this is one group of etiology of shortness of breath. Then cardiac arrhythmias, any tachyarrhythmias, usually tachyarrhythmias like atrial fibrillation or heart blocks, which lead to the dissociation between the mechanical part and the electrical part, and hence the diastolic volumes of cardiac inflow are affected. So these are the predominant reasons of cardiac causes of acute dyspnea. So just like pulmonary etiologies, this is another snapshot summary of what we just discussed in the previous flow chart algorithm. So in cardiac, think of the pump failure versus the other etiologies, ischemia, valves, and rhythms. So this is a good way of differentiating between the two. We have metabolic causes and miscellaneous. So after pulmonary, cardiac, now we are talking about metabolic and miscellaneous causes. We have discussed this previously, so let's just quickly recap. So any metabolic etiology leading to acid-base disturbance will lead to shortness of breath. That's because of the chemoreceptors and hyperventilation to try and blow off the acidic CO2 and try and normalize the acid-base balance acutely, eventually leading to the chronic compensation or subacute compensation by the kidneys in terms of regeneration of bicarbonate. So any metabolic cause, think of the mud piles mnemonic we discussed earlier. So metabolic acidosis due to, which can be the commonest ones are diabetic ketoacidosis, renal failure, which is predominantly usually acute renal failure, lactic acidosis due to any cause like anaerobic respiration or ventilation, any causes leading to higher anaerobic ventilation, which leads to lactic acid formation, or metformin, some of those drugs. Salicylate poisoning, aspirin overdose, that's one of the very common reasons in overdoses. Liver failure itself can be a cause of lactic acidosis and metabolic acidosis as well. Other metabolic group is anemia, any etiology leading to chronic anemia, usually if there is acute decompensation. Usually chronic anemias are pretty well tolerated until and unless the hemoglobin is so low that leads to extreme fatigue and weakness and all the symptoms, and the patients present to hospitals. But usually if it's acute anemia, then it's more acute shortness of breath. But chronic anemias are predominantly very well tolerated over a period of time. And same is hypothyroidism. So that's another condition leading to which can lead to difficulty in breathing. In terms of miscellaneous causes, once you have excluded all the organic structural etiologies or serious etiologies, then diagnosis of exclusion can be hyperventilation, anxiety, or panic attacks, or it can be just physical deconditioning due to obesity or poor physical fitness, which can be reversible or irreversible depending upon the clinical situation. So again, this is a summary slide of what we have discussed in the last flow chart. Non-cardiopulmonary etiologies, metabolic, hematological, and also we just need to add the neuromuscular category. Okay, colleagues, so after the whole presentation, we are at the last 4 slides, and to summarize the module 1, key take-home message is that acute dyspnea is more of a symptom, and you have to ask the patient how the patient, he or she feels, and it's not a sign itself. And also hypoxia doesn't mean acute dyspnea, and neither acute dyspnea means hypoxia, so you have to take it into objective parameters. However, hypoxia and tachypnea are the objective signs which you are assessing for patients who present with symptom as dyspnea. Again, as I said, in acute dyspnea, the patient may have normal respiratory saturations, especially when they're hyperventilating. So do not be misguided by the peripheral saturations, which can be normal. The mismatch theory is very important in the physiological mechanisms of neuromechanical dissociation. That's a core component between the central respiratory drive by the brain and the lungs mechanical output. And the global burden wise, it's one of the top 3 emergency presentations in the world, and also more than half of those patients presenting to ED will require admission, unlike 2 to 3% of the patients, or sometimes less than 2% with chest pain. So this is really important. And summary slide number 2, classification framework. Please remember the time frame: acute versus chronic. Acute is usually up to within minutes to hours, maximum a few days, versus chronic, which is usually weeks to months. So that's number 1. The other point is, please do remember the big 4 buckets of classification system to avoid problems. So pulmonary or respiratory etiology is number 1, which we have gone through the subsequent anatomical details. Cardiovascular, number 2. And remember, if you can recall, in terms of the 85% of the presentations are due to predominantly pulmonary, cardiac, or cardiopulmonary, like a combination of the two. So these are 85%. The rest of the 15% are the neuromuscular, metabolic, systemic causes, and then think of those 5 P's as I was discussing earlier. So this is another take-home message. Finally, what's next after this? So please stay tuned, because the next module will cover the ED diagnostic approach. Once we have the etiologies, classification, we are going to practically put all those into a real action from the theory part to the practical part. So that's going to be our module 2 and module 3. And also in module 2 you will have detailed about history and examination, so what to look for from clinical reasoning point of view with acute dyspnea. Module 3 will cover the investigations and management part, and finally module 4 will be the exam corner, which will also be covered. The exam tips will be covered in modules 2 and 3. So please stay tuned and enjoy your learning as you go along. That's the most important part, and do not forget about the patients, who are the most important element into all this, the core knowledge that we are applying for.